So, hello everyone. Topic for today's discussion is disorders of purine and pyrimidine metabolism. This topic is important because, as we know, that diseases like gout, nephrolithiasis, uric nephropathy, and effect of any medications, and there are some rare but important diseases are there which are associated with defects in purine and pyrimidine metabolism. So, if we focus on this topic today, we will be able to understand these topics better. Let me introduce myself. I am Dr. Devender Bairwa. I did my DM in clinical immunology and rheumatology from JIPMER. Previously, I worked as senior resident in rheumatology in AIMS Delhi, and I did my MD medicine from AIMS Delhi and MBBS from MC. Let's move forward to topic. So we will be discussing this topic under following headings. We will first introduce ourselves to. We will first introduce the topic to you. Then we will see one typical case scenario. Then we'll go with the uric acid metabolism. Then hyperuricemia. Then we will see about management of different hyperuricemic condition in brief. Then we will see some purine disorders briefly. Then some pyrimidine disorders, and this is how we'll conclude the discussion. So this figure is quite familiar to us as we all have seen this figure since our class 11th. We know that DNA composed of these bases, adenine, guanine, cytosine, thymine, uracil, depending on their ring structure, they can be divided into two types, purines and pyrimidines. In purines, we have adenine and guanine. And in pyrimidines, we have cytosine, thymine, and uracil. I remember purines like AG, adenine, and guanine. They're part of purines. So these two have different pathways for their formation as well as their metabolism, and defects in both of them are common. In your books, much is written about purines. So purine is actually more important topic than pyrimidines as far as questions are concerned. Coming to functions of these bases, they are actually part of genetic material, so they're important for application of genetic material. They are important for gene transcription and protein synthesis, and they are important in various cellular metabolic pathways. Like as we know, ATP contains your adenosine. ATP is basically currency of the cell, and that's how these different molecules are involved in various cellular metabolism also. So coming to case scenario, let's say we have this is a hypothetical case, but you can relate to that. Three medicine residents, after double emergency duty, went shopping for a mini stress buster party. Let's say they want to buy something to eat and something to drink. Out of these three residents, one of the residents has hyperuricemia. His current uric acid is 11.8 milligram per deciliter, and he had history of two gout attacks in the past. So care has to be taken for the same while shopping because one guy has this history of hyperuricemia and gout. So probably whatever they want to eat and drink should not precipitate the gout attack, or at least should not increase the uric acid. So this is our first resident, second resident, and third resident. So these are Private, Skipper, and Kowalski. All these three medicine residents did head to a party, and now they want to buy stuff. So let's see what options are available. So as far as food material is concerned, let's say what we have. So we have availability of red meat, we have availability of fish, we have availability of seafood, then we have citrus like lemon, then we have tomato. Basic idea of putting this slide is that we want to know what materials out of these are safe. It can be taken by gout or hyperuricemic patients. Similarly, let's say what drinks are there. Liquor is there, wine is there, then there is whiskey is there, beer, and let's say your sweetened drinks like Coke, Pepsi is there. Then we have coffee, tea, then we have full cream milk. We also have skim milk. So out of these drinks, idea of putting this slide is what drinks can increase the risk of hyperuricemia. Okay. So this was case scenario. Now let's see in brief about uric acid metabolism. So as we know that these purines, that is your adenine and guanine, when they're broken down, ultimately in that multiple step pathway, it gets converted into hypoxanthine. Then xanthine oxidase enzyme will work on hypoxanthine, and this will be converted to xanthine. And once this xanthine is formed, then xanthine oxidase enzyme, which works here also and here also, will convert this into uric acid. So in earlier in smaller forms of life, like in non-primates, mammals, and other animals, generally they have also one uricase enzyme, and that uricase enzyme actually it breaks down this uric acid into allantoin. So what used to happen? They used to release their excreted product of purine metabolism in the form of allantoin. This used to require a lot amount of water. Now, as we have evolved with time, in suppose somewhere roughly in Mesozoic era, we lost that enzyme of uricase, and now we are not able to form allantoin anymore. And now, in our case, the final end product of purine metabolism is uric acid. So there are different theories why we lost this enzyme. One theory is that uric acid is one of the strongest uh, uh, oxidant in the body, so it is required in the body. Other theory is that as with time we became erect, we need to have more blood pressure to have blood flow to our brain. And uric acid leads to some endothelial injury in kidneys that leads to increase in blood pressure. So there are different theories, but the point is that in our case in humans, the end product of purine metabolism is uric acid. And this uric acid has to be excreted. So let's see what this uric acid composed of. So this is the final breakdown product of purine degradation in humans, and it is a weak diprotic acid. Diprotic acid means that it will have two achions, so it can give two achions with pK value of 5.75 and 10.3. So what does that mean? So that means uric acid has tendency to give two protons. One proton will be dissociated when uric acid is acid, right? So at low pH it remains like acid. As pH increases, it will release its H-ion. So one H-ion is released from the uric acid at at pH of 5.75. So pK 5.75 means at this pH 50% of uric acid will be in the form of monosodium urate. So suppose theoretically if pH is further increased to 10.3, then at 10.3 half of the substance will be in form of disodium urate, half of the substance will be in monosodium urate. So as we know in the body pH is roughly 7.4. So 7.4 pH is well above 5.75. So most of the form of uric acid is actually in the form of monosodium urate. So 98% of our uric acid pool in the body, in the serum, is in the form of monosodium urate. So generally in body, we don't have a pH condition of 10.3, but we have condition of 5.75 and above. So in case of your urine, generally urine pH is less than 5. If a patient is healthy, he can acidify his urine nicely, then pH is less than 5. So in urine, your uric acid remains uric acid and it crystallizes also very fast. We'll see in the subsequent slides. And in case of your body, it generally remains in the form of monosodium urate. That is why we found monosodium urate crystals in tophus and gout joints. Okay. So hyperuricemia, when your blood level of uric acid goes more than 6.8 milligram per deciliter, it is taken as hyperuricemia. The idea is that beyond this point, beyond this level of 6.8, uric acid tend to saturate in the blood and tend to crystallizes. So this is how this value has been taken. So hyperuricemia, when somebody's serum level is more than 6.8, it can be taken as hyperuricemia. So uric acid is most abundant antioxidant in the body, uh, as we discussed earlier, because with the time as we evolve, we have increased burden of oxidant injury in the body. To counter that, we have developed this loss of uric acid enzyme, uric acid accumulated to be as most abundant antioxidant in the body. So let's see normal urine pool of the body. So generally, in case of males, the normal urine pool of daily urine pool is around total urine pool is around 500 to 1000 milligram. In case of female, it can be somewhere from 750 to 1500 milligram, depending on whether they're premenopausal or like reproductive age group or menopausal group. Then daily, out of this whole unit pool, about 75% is replenished. So 75% is being changed daily, and it can saturate in urine. If suppose pH is low, pH is below 5, then at uric acid level of 6 to 15 milligram per deciliter, it can saturate and it can form your crystals. But if you increase urine pH by alkalizing it, suppose you give bicarbonate therapy, or suppose acetylamides is being taken and pH is increased to 7, then the level at which this uric acid, or let's say your monosodium urate, will crystallizes at the level at a level of 158 to 200 milligram per deciliter. So understand this. So because at higher pH, higher concentration is required to crystallize this uric acid crystals in the urine. That is why one of the mechanisms to prevent uric acid nephropathy is that you alkalize your urine. So you alkalize your urine. After alkalization, the concentration required to crystallize this crystal also increases. Then in the urine, generally, it is not in the form of your uric acid completely. Apart from uric acid, there can be other forms like monosodium urate, disodium urate, potassium urate, ammonium urate, and calcium urate. So all these forms are released. As your pH will increase more than 5, then mostly these ionized form will be excreted in urine, and these ionized forms will be difficult to crystallize, so easily can be excreted. Coming to handling of total body urate pool, how it happens in the body. So there can be two ways. Either there is a de novo biosynthesis, or there is nucleic acid pool that can go to form nucleotides. And these nucleotides, apart from that, we have diet. Diet can provide our nucleosides and bases. These nucleotides, they are when broken down to nucleosides by metabolism, then form bases. Bases means these inosine, guanosine, adenosine, all these are there. So we know that body has two pathways. One de novo biosynthesis pathway is there. Then other thing is salvage pathway is there. In this salvage pathway, as we will see in subsequent slides, in this salvage pathway, these bases can be further utilized again, and they can also form their nucleotides. For example, inosine can be used to form inosine monophosphate, then adenosine phosphate. Similarly, guanosine can be used to form guanosine monophosphate, and subsequently they'll be used as nucleotides. That can happen. Suppose if it is not happening, then all this will come and it will undergo multiple reactions, and it form urate, uric acid or urate, you can say. Then this uric acid has to be excreted. So generally there are two routes of excretion. One is urine, one is intestine. So common route is your kidney. 75% of uric acid formed in the body daily is excreted by kidney, and 20 to 25% is excreted via intestine. Suppose if it not being excreted out of the body, then it can accumulate in the body, like soft tissue swelling can be there, can be deposition in joints. Soft tissue swelling, if they are deposited in the body, they are known as tophi. So understand this. In patients who have renal dysfunction, CKD, in those patients, they may have increased excretion of uric acid from other routes. What I mean to say that CKD patient tend to excrete more uric acid via their intestine compared to healthy controls. Okay, so this is the most important figure of this chapter, and this chapter will show you how uric acid is handled in the body. So understand this figure. This figure is basically a cross-section figure of your proximal convoluted tubule part of your nephron. So this side is actually luminal side, or we can say urine side, and this is basal side. So what happens? Imagine that afferent artery coming like this, and then this filtration of your blood, formation of urine. This urine is going down like this in the lumen, and this is your part of tubule, your PCT part, and then the multiple transporters are there, and multiple things are being secreted. So now understand this. This is apical membrane, and this is the lumen of your tubule, and this is basal membrane, and this is post circulation. So out of transporters, important transporters include urate-1, uric acid apical transporter 1, urate-1 is there. Then this SLC5A8, SLC5A12, then your SLC2A9V2 is there, GLUT9 delta copy only, and then organic anion transport 4 is there. So now see there, this urate-1, its main function is to absorb whatever uric acid has been filtered uh, via glomerulus and whatever has come to your urine. Uric acid can be absorbed with the help of urate-1 in exchange of organic anions and monocarboxylates. For example, your lactic acid. Suppose body has more lactic acid, then this lactic acid can be excreted in exchange of uric acid via urate-1. So this is one of the mechanism how hyperlacticemia, or let's say alcohol which forms lactic acid, how it can lead to hyperuricemia. So this mechanism is there. Similarly, if you see OAT4, in OAT4 it also absorbs your uric acid, and in exchange of that it is actually giving dicarboxylates. So there are multiple drugs are there, like nicotinate is there, pyrazinoate is there. So these are multiple drugs are there, multiple things are there. So what they can do, these can be exchanged for your uric acid. So these are the mechanisms through which your uric acid can be reabsorbed. Similarly, this SLC58 channel can absorb your monocarboxylase again back in your PCT cell along with sodium. Now see this GLUT9. GLUT9 actually transport uric acid along with glucose and fructose. Now this capacity of GLUT9 to transport uric acid is very high. So in compared to fructose and glucose, it requires at least 50 times uric acid concentration to saturate this pump. So what happens? So whatever glucose, fructose you will give, it will keep absorbing it with uric acid. So this is the mechanism how and why these sweetened sugar drinks, they increase hyperuricemia, because they contain fructose, and when this fructose it reaches to your lumen here after filtration, this fructose can along with uric acid be reabsorbed in this cell using this GLUT9 pump. So these are your multiple your pumps that are being used by the kidney to absorb uric acid. This OAT4, organic transport 4, is present on the apical side. OAT1 and 3 are present here. These two are same, they are the product of same gene with some different splicing. So GLUT9 and GLUT9 delta N, these are there. Then SL13A3 is there. It is actually taking sodium and dicarboxylates inside. Apart from these proteins, there are some other proteins which are not mentioned in Harrison but which are important. Includes NPT1, MRP4, ABCG2. So these proteins are actually present on the apical side, and they are actually your important for your excretory function. And OAT4 and OAT10 are also there. OAT4 we can see here. Also OAT10 is there, and these are actually using absorption of uric acid. So what happens? There are two terms known as cis inhibition and transstimulation. So what happens? There are drugs which can be drugs or substances which can be which can be utilized by these pumps so that uric acid can be absorbed. Suppose if you are giving lactic acid in the body and lactate is being excreted and then there is intake of uric acid, then this is known as your cis inhibition, because this uric acid absorption is increased. Or what can happen, there can be drugs which can actually help your release of your uric acid from the body. In that case, it is known as transstimulation. So these cis inhibition and transstimulation, these both process occurs on apical surface only. So this is the mechanism how your uric acid being handled in your kidney with the help of different proteins or pumps that can lead to hyperuricemia. Now understand this, different studies have shown some single nucleotide polymorphism like things for urate-1, ABCG2 and other proteins, due to which there can be some variation in the uric acid levels in different ethnic groups. Okay, so now we have seen these proteins, and now we can see these proteins, they have been utilized as the pharmacotherapy mechanisms So let's say lesinurad, it's a new drug, not a new drug. This drug is there in the market for so long, maybe some 5-6 years. Lesinurad actually works by inhibiting urate 1 and OAT4. So we know urate 1 and OAT4 both are involved in reabsorption of uric acid in the PCT. So if it is inhibited by this lesinurad, it can lead to more excretion of uric acid and amelioration of hyperuricemia. Then we have arlofenate. This is originally a PPR gamma modulator, but it can also inhibit urate 1, OAT4, and OAT10. So these two drugs are utilizing, out of these new drugs, these two drugs are utilizing these mechanisms of your renal handling of uric acid as their mechanism of action. Coming to uric acid again, then let's see. Earlier, what they used to say that this is a disease of the kings or king of the diseases. Earlier, people with sedentary lifestyle, like these kings in the earlier time, they used to have this disease. They used to have this tophaceous gout, so many nodules in their hands and the knee joints, ankle and MTP joints, because they used to have a sedentary lifestyle. They used to have a high meat intake. They used to have a low daily exercises, and then they used to have high liquor intake. Everything it used to take it to hyperuricemia and gout. But nowadays, uric acid arthropathy has become very common. So now it is known as disease of the commoners. And in fact, it is one of the rapidly increasing inflammatory arthropathy in the Western world. So now it is no more known as the disease of the kings, but now it is known as disease of the commoners. It is more common in your Black Americans than white Americans now because of multiple factors. And now we already discussed this that all that other animals except primates and us, they have uric acid enzyme, and because of uric acid enzyme, they don't form uric acid. But in general, these your primates, which who are actually living jungles, they eat these all herbs and lots of fiber is there, and their uric acid actually remains low, below 3 milligram per deciliter. And that may be the reason why gout is exclusively a human disease. There are no animal models for this disease. We can create animal models by different techniques, but as such, there are no other animal models as gout is exclusively human disease. In case of children, the level is low. Generally, it is 3 to 4 milligram per deciliter. And in case of males, when they hit puberty, during that time when their muscle mass is increasing, their activity is increasing, that time their level begins to rise. But in case of females, that uric acid level remains low, and it will start increasing once they achieve menopause. And overall, females have lower uric acid. Somewhere like the difference between males and females is more than 1 milligram per deciliter, and that difference is because of mostly because of action of estrogen, as estrogen has uric acidic activity. So when menopause is achieved by females, at that time they started having low levels of estrogen. Low levels of estrogen means low uric acidic activity, and that leads to your high levels of uric acid. So this is the fundamental point why females will start having hyperuricemia at menopause. So this data from NAINS data is from US. So in the data, NAINS 3 data has shown that the average male and female level is somewhere 6 and 4. Coming to hyperuricemia, so we already have discussed that hyperuricemia means that somebody's level is more than 6.8. Prevalence of asymptomatic hyperuricemia is around 20% in population in the various studies, but prevalence of gout is 2%. So understand this. Although 20% of population will have hyperuricemia, but only 2%. It means out of 20, only 2%. That means only 10% of asymptomatic hyperuricemia will progress to development of gout. That gives you two important points. So first thing is probably hyperuricemia is not sufficient enough to cause gout. And second point is there is no point of treating all the patients of asymptomatic hyperuricemia, since the proportion of patient who will develop gout is low, 10%. So it is not cost effective to treat asymptomatic hyperuricemia. So we will see subsequently in our management plan that these patients are generally not treated. So only 10% of asymptomatic will develop gout. Then we already discussed that worldwide gout incidence is increasing, probably because of change in lifestyle. So coming to causes of hyperuricemia, there are two ways we can divide hyperuricemia causes. So one way is, this is like more clinically better. So there can be either reduced excretion. So these are known as under excretors. So what can happen? There can be some defect in the kidney, or there can be some drugs, or let's say some disease, which is leading to reduced excretion of your uric acid from kidney. So these are known as under excretors, and 80% cases of hyperuricemia is are generally because of your reduced excretion. For example, your kidney disease is there, or let's say some drugs are there, or let's say your some food materials are there which are interacting with the uric acid, or there can be increased production in 20% cases. For example, there can be a ongoing malignancy can be there can be cytolytic therapy is there, rapid turnover of cells can be there. So all this will lead to more production, or there can be some defect in enzyme, or there can be cases where both causes are involved, reduced excretion as well as increased production. Other way of dividing causes of hyperuricemia is primary and secondary. Primary means there is innate defect. So, for example, HPRD deficiency is there, PRPP over activity is there, some kind of genetic defect is there. Then it is primary. Secondary means acquired defect. So, acquired defect can be because of some disease like CKD, diabetes, hypothyroidism, or diabetic ketoacidosis. These can be there. So either you can divide this causes hyperuricemia according to the mechanism or according to the cause. So generally we tend to use both of these methods when we see our patient clinically. So this table is from Harrison. It is showing classification of hyperuricemia by pathophysiology. We can see there are causes of urate overproduction. We can see causes of reduced excretion, and we can see there are combined mechanisms like alcohol shock, fructose deficiency, glucose 6-phosphatase deficiency. All these are mentioned there. Then they have shown, this table is showing from Harrison multiple drugs which are having uricosuric activity. It means they're good in gout, they're good in hyperuricemia. If you provide those drugs, maybe they will help reducing your blood levels of uric acid. So, but these tables are exhaustive and they're, you cannot remember all of them. So we have kept some important points that you should understand. So let's understand what are the factors associated with urate level variation. Means what factors can lead to high as well as low uric acid level. So in irreversible factors, we have age. So as we have seen, only for females it is countable, because in case of males that level start keeps increasing with the age, but in case of females it remains stable, and after menopause it starts increasing. Gender, male is important because they have approximately 1 milligram per liter higher than females, their level, mostly because of low level of estrogen and high muscle mass. Then some races can have, in general, they can have high levels of uric acid, including blacks, Maori people, and Taiwanese people. And urate 1, ABCG2, SLC2A9, all these proteins, their single nucleotide polymorphism can be there, and mostly these races have this kind of polymorphism only, and that is how they have difference in their levels of uric acid. Coming to other factors, so adiposity is there. It increases uric acid production as well as it reduces clearance of uric acid. Then red meat is there. So in generally what happens, this red meat will have high purine content, and it will also have high trans fats. So apart from having high purine contents, then this high trans fats, when fats are there, it causes insulin resistance. In general, insulin sensitivity, it leads to increased uric acid secretion in the urine. So if insulin resistance is there, then again it will lead to hyperuricemia. So these are two mechanisms via which your red meat is causing hyperuricemia. Seafood also contains high amount of purine content. It can also lead to hyperuricemia. If we look for dairy products, if these are low fat containing dairy products, they have been beneficial in uricemia. For example, if somebody is taking skimmed milk, then skimmed milk will be actually helpful. It will help reducing your uric acid. But if you start taking your full cream milk and high fat content milk, then mostly because of that fat, there can be again insulin resistance, and there can be increased uric acid levels. So in dairy products, low fat containing dairy products are actually beneficial. Then coming to your vegetables, purine-rich vegetables, for example, tomato. So these are actually good source of purine, but what happens? Generally, these vegetables, they contain high amount of your dietary fiber, and they have a low bioavailability. So despite having high purine content, these vegetables are actually good, and they can actually improve your insulin resistance. So now these purine-rich vegetables are no more contraindicated in your hyperuricemia patient, and they can be taken. So as far as your liquor is concerned, beer is worst because beer contains high guanine content, and then whiskey is moderate, and wine is little amount of wine is good, like up to 2 drinks it is good. Otherwise, beer and your whiskey is worse, and beer is the worst because it contains your some beer contains your high guanine content. So ultimately, it will lead to high purines. Then sugar sweetened drinks, diet cola is okay, but because diet cola contains your less fructose, but otherwise in generally your Pepsi, Coca-Cola, and other these drinks, they have high amount of fructose. And as we have seen that this fructose is absorbed with the help of your SLC glut delta 9 your pump with the uric acid, so it can also lead to hyperuricemia. Coffee contains methyl xanthines, and we know methyl xanthines are actually natural inhibitor of xanthine oxidase enzyme. So these are beneficial. Coffee is beneficial. Also, coffee improves insulin resistance. So coffee is good in hyperuricemia. Tea has been found to have no effect on this thing. So we don't know whether tea will increase or decrease. So tea is also safe. And vitamin C is good. So vitamin C is one of the drugs which is used as uricosurics. Coming to medications, so there are good drugs and there are bad drugs. So these good drugs are drugs which are causing uricosurics. So mostly these are your drugs which will help more uric acid excretion kidney. Includes fenofibrate, losartan, vitamin C, leflunomide, CCB, and sevelamer. Bad drugs, the drugs which are there, which will be like most of them will be monocarboxylase and dicarboxylase, and they can be exchanged with uric acid. So pyrazinamide, ethambutol, diuretics, nicotinic acid, levodopa, cyclosporin, tacrolimus, and chemotherapy. So these drugs are you would have seen in your clinical practice, or they are mentioned in multiple MCQs. Pyrazinamide and ethambutol, we know when we give it ATT, these are there. Diuretics, we know thiazides, and your to some extent your furosemide will also be causing this thing. Then cyclosporin, tacrolimus, we know because we give these drugs, and chemotherapy, we know there will be more uric production. So all uh, these drugs are involved in your hyperuricemia, and these drugs are actually helpful. Then environmental factors, lead poisoning is known as saturnine gout because there can be hypertension, renal failure, and hyperuricemia. This triad is there. That is known as saturnine gout. And then hot and humid environment can actually precipitate attacks of gout because we know there will be more saturation with dehydration of uric acid, and it can lead to more attacks of this thing. So these are the important factors clinically which you should know, uh, which actually affect uric levels. Then this table is showing conditions, medical condition, common conditions, and rare condition, which can also lead to high uric levels. So common condition, increased cell turnover, as in malignancy and psoriasis. Then renal failure is there, low GFR, low urate excretion, immunity disorders, and metabolic syndrome. So all these are associated with your hyperuricemia. Then rare conditions like HGPRT or HPRT deficiency, Lesch-Nyhan or Kelly-Siegmiller. Complete deficiency is known as Lesch-Nyhan syndrome, and partial known as Kelly-Siegmiller syndrome. Then we have PRPP, synthase overactivity. This is the first enzyme which is known as pathway. And because of overactivity, there is more PRPP. It leads to more raw material for the pathway, and that's how more uric acid forms last. Then glucose 6 phosphate deficiency, fructose 1 phosphatase aldolase deficiency. This is known as hereditary fructose intolerance. So these two pathways leads to more ATP depletion in the more stress and more ATP depletion in your cell, leading to ultimately more uric acid. Then your glycogenic disorders, myogenic forms, McArdle's, Thyroid disease, or Cori-Forbes disease. All these enzyme deficiencies can lead to your cell death and cell turnover increase with increased uric acid production. Then uromodulin associated diseases are there. So uromodulin protein is basically same as TAM-Hochfall protein, and it is required for maintaining your gel-like coating over thick ascending loop of Henle. So this uromodulin defect can be found in your familial juvenile hyperuricemic nephropathy. Then medullary cystic kidney disease 1 and 2. So these are rare diseases, but you should know that. So these are common conditions, and these are rare conditions which are associated with your high uric levels. So coming to pre-metabolism, I know this figure looks very horrible to see, but let's try to understand this in a simpler form, simpler way. You need not to remember mug up this figure, but you should understand the basic steps which are occurring. So let's say we start from 1, 2, 3, and then we'll go further. So let's see. So, okay. So in this figure, if you see, ribose 5-phosphate and ATP is required to formation of PRP. So this PRPP is your 5-phosphoribosylpyrophosphate pyrophosphate. This is basically your starting material for your this pathway. So what happens? This with the help of your PRPP synthetase, that is enzyme number one. This enzyme 1 PRPP synthetase is required for formation of PRPP with the help of ATP and ribose 5-phosphate. So what happens? This PRPP is actually raw material, and this your the rate of reaction will depend on the availability of PRPP. So in case of PRPP oversynthesis, PRPP synthesis overactivity, more PRPP available, and that leads to actually formation of more urate in the last. And this is how this PRPP synthase overactivity is associated with gout. So understand this defect. Then what is happening? Then PRPP is binding glutamine with the help of the enzyme, your amidophosphoribosyl transferase amido PRT. Amido PRT is actually your rate limiting step of the reaction, and this rate limiting step, and then this availability of these things required. Then formation of PRA is there, formation of SICAR. SICAR forms ICAR. There's formation of IMP. IMP forms your inosine. Inosine forms your hypoxanthine. Hypoxanthine is converted to xanthine and then urate. This hypoxanthine and xanthine reactions, both these reactions are by your, if you see, this is where xanthine oxidase. This is required. This enzyme is inhibited with the help of xanthine oxidase inhibitors like allopurinol or your Physiology. So these two drugs are being utilized by inhibiting these two reactions. Then we have this. This is the part of your uh, salvage pathway. If you see, so what is happening? This 8 number enzyme is actually your HPRT enzyme. If you see hypoxanthine phosphoribosyltransferase transferase. So what happens? This enzyme is involved in your salvage pathway. So once your hypoxanthine is formed, still there is a chance that it can be recovered. So with the help of your this thing HPRT, then this hypoxanthine will be converted to with the help of PRPP into IMP. Once IMP is formed, then again it can be utilized to form AMP or GMP depending on what the body wants. And then purine nucleoside cycling is there, and also health cycling is there. So this adenine can be utilized for formation of your this thing. So guanine can be converted into GMP with the help of HPRT, or hypoxanthine can be converted into adenosine monophosphate. So this is the part of salvage pathway. So this much you should know. This enzyme number 1, enzyme number 2 is important, and then you have enzyme number 10 that is important, enzyme number 8 that is important. So let's say, so amidophosphoribosyl transferase amido PRT. It means second number enzyme. It is rate limiting step. That is important. Then hypoxanthine phosphoribosyl transferase HPRT. Earlier books used to write it like SGPRT. It is this 8 number enzyme, and it is important for salvage pathway. Then you have this PRPP, this phosphoribosyl pyrophosphate, PRPP. It is the rate limiting substrate. So if it is available more, reaction occurs more. If it is less, reaction occurs less. So these three things you have to remember out of this figure. So let's see increase urate production. So if suppose we do a strict diet restriction, we don't take purine rich food, then we can reduce our serum uric acid level by 1 milligram per deciliter. And urate excretion reduces by 200 milligram per day in your urine. And there are conditions which are associated with increased urate production, like we discussed already, including leukemic blast crisis, cytotoxic malignancy, hemolysis, rhabdomyolysis, or there can be conditions where there is excessive degradation of ATP in skeletal muscle tissues, like somebody is doing strenuous physical exercises, or conditions associated with status epilepticus, then glycogen storage diseases, which actually affect muscles, including type 3, type 5, and type 7. So these are basically your coryphobes and myocardials and thyroid disease. So all these conditions are associated with depletion of ATP and more formation of uric acid. Or there can be stressful conditions like myocardial infarction, smoke inhalation, acute respiratory failure. All these conditions will lead to accelerated breakdown of ATP. All will lead to formation of high uric acid. Then reduced uric excretion. So sustained hyperuricemia, mostly 90% in cases of hyperuricemia are because of under excretion of urate, reduced excretion of urate in the urine. And if you see these gout people, in gout people compared to healthy controls, they have 40% less excretion of uric acid at any serum level of urine. Then there can be three different things. They can be either reduced GFR, that is because generally in case of renal insufficiency, as your blood flow to kidney or GFR reduces, then there will be reduced excretion of uric acid in your urine. And but this level of uric acid has poor correlation with increasing urea, creatinine, and blood nitrogen. Then there can be decreased tubular secretion that occurs with when there are multiple substances which are interfering, or there can be enhanced tubular resorption. So as we discussed earlier, there can be transstimulation. There are substances like pyrazinoate, nicotinate, lactate, beta hydroxybutyrate, estroacetate. All these substances are there ready to be exchanged with uric acid. That's how they can lead to hyperuricemia. Or there can be sodium loading of PCT. Like what can happen? Suppose if there is sodium loading because of high salt intake, then there can be urate retention by reducing extracellular volume. So once extracellular volume is reduced because of your this thing, then urate will be retained in the cell to maintain the volume. Or there can be enhanced GLUT9 activity. The GLUT9 is same pump which is involved in transport of your uric acid with fructose and glucose. So these are three different mechanisms through which there is under excretion of uric acid in the urine. Coming to effect of alcohol, so there are different ways through which alcohol can lead to hyperuricemia. One thing is there can be increased hepatic ATP breakdown. We know because alcohol is being handled by your liver, there can be increased ATP breakdown. Then one of the end products of alcohol metabolism is lactic acid. So once there is more lactate, this lactate is available for transstimulation. In PCT can be exchanged with uric acid. Uric acid can be absorbed and lactic acid can be excreted. Then, as we discussed, some beers can have high alcohol content, and in generally what can happen, there can be low calorie intake. When there is low calorie intake with alcohol, then there will be more breakdown of your body stores, more ATP release, more ATP breakdown. That can lead to also your hyperuricemia. These are different ways through which alcohol can lead to hyperuricemia. So coming to evaluation, so any patient who presents to you with the hyperuricemia or let's say gout, how do you go? So somebody is having hyperuricemia, it means blood level is more than 6.8. So try to see for the causes which can explain whether there is any reduced urine excretion. Like suppose presence of CKD or renal insufficiency is there, or some drugs are there, or other diseases are there, or there are conditions which can be associated with increased urine production. Like suppose somebody is having a tumor or somebody is on chemotherapy, that we need to see. So this increased urate production, how do you confirm it? So what you can do, you can look for 24-hour urate excretion in the urine. So suppose somebody is on purine-free diet and is excreting more than 600 milligram of urate per day, or on a normal diet more than 800 milligram, then mostly there is overproduction of your uric acid in the body. So mostly we are dealing with the excuse me, increased urate production. Suppose this is not there, then mostly it is the reduced urate excretion which is the cause of your hyperuricemia. In some cases, there can be combined causes. So, what are the complications of hyperuricemia? There can be formation of gout, nephrolithiasis, nephropathy, uric acid nephropathy. So, all these four things can be seen in different times in patients of hyperuricemia. Coming to gout, to understand that gout term has come from gatta, and gatta, the literal meaning of gatta is droppings. Earlier, it was postulated that gout is occurring because of dropping of bad substances in joint. And when they used to see these crystals, it used to appear some like bad droppings in the joint cavity, and that's how gout term has come. Then tophus is soft tissue deposition of your monosodium urate crystals. It has come from tophos, and tophos means chalk. And then you need to understand that gout of first MTP is known as podagra. Podagra is an old literature term, and the meaning of podagra is food seizure. So this term has come because when these patients of gout will have pain in their first MTP during acute gout, they will not be able to keep it calm. They'll keep moving it with the fine movement because of pain, and that appears like a food seizure. So that's how podagra term has come. Then already we discussed prevalence of asymptomatic hypoglycemia is 20%, but gout will occur only in 10% of these. It means 2% overall. So only 10% of people will have gout. So gout generally, its natural history goes through four different phases. One phase of asymptomatic hypoglycemia. It can be of any time. Nobody knows how long it will be there. It was there earlier before the gout, and will be generally it will be associated with component of metabolic syndrome or CKD or congestive heart failure or hypothyroidism. Something will be there. Then patients will develop acute gout. Then after acute gout, they can have intercritical period that can last from months to years. And after that, when patient will have repeated acute gout attacks, the time will come then chronic tophaceous gout will develop. So these four phases can be seen in natural history of gout. So acute gout, generally when acute gout occurs, there will be a overlying skin of the joint, mostly presents with the involvement of either first MTP joint or ankle or knee joint. Generally, overlying skin will become red because of your monosodium urate crystal induced cellulitis. It means with the involvement of joint itself, there can be involvement of skin also. And in case of women, when they are affected with this disease, generally they are affected in postmenopausal phase, but there can be a oligo or polyarticular first presentation. And once acute gout attack happens, this attack lasts for 3 to 10 days, and without treatment, it tends to subside in the beginning. And these patients, when having acute attack, can have also fatigue, fever, and chills can occur there. Generally, you would have heard or read or seen clinics that most attacks of the acute gout they occur in night. There are multiple reasons why these attacks occur in night. So in the night, there's low temperature, there's low pH because there's little hypocarbia in the body. Low blood flow is there because of less of activity and more of water than urate being absorbed from joint at that time. And in the night, cortisol level also falls. So all these factors culminate to have acute gout attacks mostly in the night time. So acute gout, this figure you can see, this is showing typical swelling of first MTP joint, and we can also see the redness of overlying skin. Generally, this is because of mostly because of cellulitis of the skin, because of acute inflammation. And this box is showing features of acute gout. Generally, it is an abrupt and rapid onset attack. Maximum symptoms will intensify in your first 8 to 12 hours. Attack generally come on night or early morning. Most commonly, it is monoarticular in men during first attack. In your 50% of cases, your first MTP joint is affected. After that, your ankle, heel, knee, wrist, and hands can be affected. Joints are red, hot, swollen, and severely tender. And generally, your attack will resolve within 3 to 10 days of your duration. Then we have intercritical period. So what can happen? There can be repeated acute gout attacks, and then there can be intercritical period. So intercritical period can be of variable length, but generally what happens if somebody is having one attack, then there is 60% probability that next attack will occur in 1 year, or 60% of people will have attack in 1 year, and 80% of people who have a first acute gout attack, if not on treatment, then 80% of these people tend to have the next attack within 3 years. So this is intercritical period. Then what can happen with time as there is more damage to your joint with recurrent attacks? Then what can happen? There can be development of chronic gout, chronic tophaceous gout. So what can happen? There can be like pattern symptoms can change. Earlier there was a nice gap between your attack, but with time that time between attack can shorten. More joint can be involved with time. There can be tophaceous disease with the accumulation of tophi in the joint or in soft tissues, and there can be destructive arthropathy. There can be reduced range of motion, or there can be reduction in quality of life. With time, there can be increased of nephrolithiasis, and generally there will be association with other comorbidities like metabolic syndrome, diabetes, mellitus, chronic kidney disease, cardiovascular disease, hyperlipidemia, obesity. So all these features will be seen. Coming to nephrolithiasis, most commonly nephrolithiasis is seen with gout only. So some patient will be there with coexisting, pre-existing gout, and then they will present nephrolithiasis. Then prevalence generally correlate with serum and urinary uric acid level. Means if high uric acid level, high chances of development of your uric acid kidney stones. So 50% uh, people at 50% people at 13 milligram per deciliter of uric acid can develop their uric acid stones. And if there are no uric acid stone, there can be other kinds of stones. So what happens generally in case of your calcium oxalate, or let's say other kind of calcium stones, this uric acid can work as a nidus, and once this nidus is formed, then calcium oxalate can deposit over this nidus and can form stones. So apart from formation of uric acid stone itself, uric acid can help formation of other stones also as well. Then other problem is your urate nephropathy. This condition of urate nephropathy actually develops after many years, let's say 10 to 20 years after hyperuricemia, and it is also known as urate nephrosis. There is accumulation of this urate, monosodium urate, into your interstitium and around the tubules in the tissue of the kidney. So this is generally a late manifestation of severe gout. So if you see in histology, you will see these crystals are deposited and they're surrounded by a giant cell inflammatory reaction in the medullary interstitium and pyramids. And nowadays it is rare because treatment is available, and generally patient has to have a severe gouty arthritis in the background. Then probably they will have urate nephropathy. Clinically, either this can be clinically silent or there can be proteinuria, there can be hypertension, and in some cases there can be insufficiency. So urate nephropathy is as such rare. I have never seen a case in my life. Uric acid nephropathy. So uric acid nephropathy is generally a acute presentation. So it is a reversible cause of acute renal failure. Now understand this. In urate nephropathy, because of a long-standing disease, there is accumulation of this urate in your interstitium of your tissue, basically kidney. In case of uric acid nephropathy, uric acid is being deposited, or let's say crystallizes within your tubules. So suppose a condition is there where so much of uric acid is being excreted in your urine, and that uric acid, that urine has got super saturated with your uric acid, and because of super saturation, that uric acid has formed crystals. So that condition is known as your uric acid nephropathy. So it is a reversible cause of acute renal failure. There will be precipitation of uric acid in your tubules and collecting ducts, and that will actually offset your urine flow. This is generally associated with your sudden urate overproduction and marked uric aciduria. So suppose somebody is having a cancer, let's say lymphoma is there, leukemia is there, and then you are giving some chemotherapy. So much cell breakdown that uric acid has gone to 20, 25. In such condition, this uric acid will crystallize in your tubules of your kidney. Then dehydration, acidosis, and rapid cell turnover. These are basically contributory factor in your uric acid nephropathy. Generally, this condition is seen in blastic phase of leukemia or lymphoma, or it can be seen with epileptic seizures or after vigorous exercise with heat stress. So all these conditions associated with the uric acid nephropathy. So histologically, if you will see, you will be able to see interluminal precipitates of uric acid. You can see dilatation of proximal tubules because of collection of these crystals in tubules. Generally, glomeruli are normal, and glomeruli will not be involved because these uric acid, once filtered through glomerulus, then it will go into your this thing tubules, and then it will be accumulated there. So generally what happens initially, there will be obstruction of this collecting ducts and tubules because of uric acid crystallization, and subsequently there can be obstruction of your the renal vasculature that will lead to acute renal failure. So as we see, we can see these are the tubules, and we can see there's a collection of this uric acid. This pink thing is uric acid, and because of collection there is dilation of these tubules, but nephrons appears to be normal. Okay, so this is actually potentially reversible. Appropriate therapy, if we provide, mortality can lead to zero. In untreated cases, mortality can be as high as 50%. So one specific test that is there is the ratio of uric acid to creatinine. In all acute renal failure conditions, there is reduced in output, and urinary uric acid content is either normal or reduced. That's why the ratio of uric acid to creatinine is less than 1 in all cases of acute renal failure. But in case of uric acid neuropathy, this uric acid nephropathy, your ratio of uric acid to creatinine will be more than 1. So this ratio can be calculated from the urine. If it is more than 1, it is mostly pathognomonic of uric acid nephropathy. Coming to metabolic syndrome, we know that metabolic syndrome is a constellation of abdominal obesity with visceral obesity. Then there will be some impaired glucose tolerance. There may be pre-diabetes with hyperinsulinemia, hypertriglyceridemia, increased LDL, decreased HDL, hyperuricemia. So basically, metabolic syndrome is collection of all these things. And now new studies have shown that this metabolic syndrome is invariably associated with hyperuricemia. So what happens? This hyperinsulinemia, it reduces excretion of uric acid and sodium because there is insulin resistance. In general, insulin tend to sensitize and increase your production of your excretion of uric acid from tubules. But suppose if insulin resistance is there, it will not work. Then what will happen? Your uric acid will accumulate in the body. So this is how metabolic syndrome is associated with your hyperuricemia also. Or what can happen? Suppose if somebody is having hyperuricemia in the beginning, then this hyperuricemia can predispose to your metabolic syndrome. So there are studies where they have followed up hyperuricemic people with non-uricemic people, and what they have seen that hyperuricemic people were more prone to develop diabetes, hypertension, kidney failure in the future. So in general, what we can understand that whenever you see metabolic syndrome, try to see for hyperuricemia, and wherever you see hyperuricemia, try to find out metabolic syndrome. This is the message from this slide. Coming to management, how do we manage these patients? So asymptomatic hyperuricemia treatment is not recommended because we have already seen that 90% people of asymptomatic hyperuricemia, they will not progress in their life, except conditions when cytolytic therapy is going on, like last phase of leukemia or lymphoma, or you are giving chemotherapy to patients of leukemia or lymphoma, when you tend to suspect that patient might suffer from uric acid neuropathy. These are the cases when you actually go for treatment of asymptomatic hyperuricemia. Otherwise, treatment is not recommended. But you can screen for metabolic syndrome as we discussed, and you can go for appropriate management of these conditions. And because only 10% of asymptomatic hyperuricemia will develop gout, so treatment of all the patient is not cost effective. And generally, whenever a complication develops in these patients, complication will develop mostly after first attack of gout. So when first attack of gout occurs, after that you can think about starting treatment. And even if you start treatment for asymptomatic hyperuricemia patients, what they have seen that their natural history will not change. Means their progression to renal failure, progression to hypertension, diabetes will not change. So there is no cost effectiveness of treatment. There is no change in natural history of disease. So there is no point of treating asymptomatic hyperuricemia except when cytolytic therapy is going on. So gout and urate nephrosis we will not discuss here because it's part of one other discussion. This discussion will be further taken up in your gout chapter, how to treat gout. That discussion is beyond the scope of this discussion. Nephrolithiasis treatment recommended. So generally what happens? Generally patient will have we treat for nephrolithiasis only in patient who has both gouty arthritis or presence of stone. Stone can be either uric acid or calcium containing stones. But if somebody is in gouty arthritis, mostly treatment is recommended for these patients. So what can we do for nephrolithiasis? Fluid injection, we have to make sure that at least 2 liter per day fluid is taken. Then we can think about alkalizing urine with the help of sodium bicarbonate or acesulfame. As you already discussed that you alkalize the urine, then that concentration at which this uric acid will be crystallized will increase. So mostly all this will dissolve and will go into the. Then you can also give allopurinol or fibrostat because they will reduce your uric acid serum level. And then you can also provide potassium citrate 30 to 80 millimole per day in divided doses because it can also lead to alkalization of urine and it can help dissolving your these stones. Coming to uric acid neuropathy, generally what we do whenever we are giving this cytolytic therapy to our patients in our the oncology wards, so we provide them because IV hydration. We also do diuresis with the Lasix furosemide, and our target to maintain a urine flow of more than 100 ml per hour. We can also provide acesulfame to 240 to 50, 500 milligram every 6 to 8 hours. And sodium bicarbonate can be also given IV to maintain alkalization of urine. And urine pH, we have to you have to target for pH more than 7. When you are giving so much fluid, then also look for circulatory overload. If patients are having compromised cardiovascular system, then we have to be little cautious. Then allopurinol is generally started as a single dose, 8 mg per kg per day. That will be roughly somewhere 300 to 500 milligrams per day. And if renal insufficiency is there, we can start with the low doses. Generally, we start with 100 or 200 milligram per day, depending on EGF of patient. And suppose if all these measures fail, generally, if you start them early, it will work. Suppose if these fail, then you can go with hemodialysis also. And we also use raspberry case, that is urate oxidase. We provide this raspberry case enzyme so that it can break down your uh, uric acid to allantoin, and then this also be being given frequently in our patients of oncology patients. Coming to hyperuricemia, so we have seen everything about hyperuricemia, increasing uric acid and its detrimental effect. So what can happen? There can be uric acid level less than 2 milligram per deciliter. That is known as hyperuricemia. So generally, it has no any major clinical impact, and this can be because of decreased production or increased excretion of uric acid or combined mechanism. So what can happen? There can be some defect in some genetic enzymes can be there that which are involved in your production of uric acid that can be deficient, or there can be some kind of polymorphism in your kidney who are handling with this uric acid which are not observed. Like suppose there is a defect in OAT1 or urate1, then there can be hyperuricemia. So generally, less than 0.2% of the population will have this condition. But as if now, no symptoms of pathology known because of hyperuricemia. There are drugs which can cause hyperuricemia, like aspirin, when it is given more than 2 gram per day. It can lead to hyperuricemia, losartan, fenofibrate, X-ray contrast material, glycerol glycolate, and then some patients who are on TP and total parental nutrition, they can also have hyperuricemia because they have high glycemic content. Or there are conditions which can be associated with hyperuricemia, some neoplastic diseases, hepatic cirrhosis, diabetes mellitus, syndrome of inappropriate eddy secretion. Then there can be problem with the renal handling of uric acid. There can be so much excretion of uric acid in the urine. Conditions like primary Fanconi syndrome, where resorption of uric acid is defective, or there can be secondary Fanconi syndromes associated with Wilson's disease, cystinosis, multiple myeloma, high blood toxicity. All this can lead to your hyperuricemia. Okay, so generally these patients of hyperuricemia will not have any symptoms, but what can happen sometimes, because so much uric acid is being excreted in your renal tubules, some patient can present with urate nephrolithiasis, or some patient can have exercise induced renal failure. So already these patients will be excreting more uric acid, and somebody is doing exercise, there can be more ATP depletion, more increase in urate, and then this urate actually can deposit in the kidney acutely, leading to acute renal failure. So these two things can happen rarely in these patients. Otherwise, hyperuricemia is a condition with no long-term clinical impact. Coming to some purine disorders, some chosen purine disorders, we will discuss about some enzyme defects. So let's see this table. This table is important because defect in different enzymes are causing some different kind of manifestations. So let's see hypoxanthine phosphoryl transferase deficiency, that is HPRT, or HGPRT deficiency. Complete deficiency, partial deficiency. So what happened in this condition? Both are X-linked. In your X-linked, in your complete deficiency, apart from your gout and uric acid lithiasis, there is self-mutilation, choriocytosis, seizures can be there. Basically, CNS involvement is there. In case of a partial deficiency, there is no CNS involvement. CNS involvement, only gout and uric acid lithiasis is there. In case of your PRPP synthetase overactivity, so see here. So as we discussed, this PRPP synthetase enzyme will lead to more formation of PRPP, that is phosphoribosyl pyrophosphate. So this phosphoribosyl pyrophosphate, it is more available, then there is more formation of uric acid. This also leads to gout, uric acid lithiasis, and there is some deafness. The reason for that is not known. Then adenine phosphorybal transferase enzyme is there. If it is deficient, it will lead to formation of 2,8 dihydroxyadenine lithiasis. So these stones are specific for this enzyme defect. Then xanthine oxidase deficiency is there. We know xanthine oxidase will lead to metabolism of your uric acid. So these patients can have hyperuricemia, hyperuricemia, They can have xanthine stones, but apart from that, there are no other things known. Then adenylosuccinate lyase enzyme is there. It can lead to autism and psychomotor retardation. All these enzymes somehow are important for this pyrimidine metabolism, which is important for your brain development. This is why in these disorders there are so much seeds involvement. Then myoadenylate deaminase deficiency, MADD. Myoadenylate deaminase deficiency is like one of the most common kind of fatty uh, fatty acid oxidase defect that is seen in your metabolic muscle diseases. So this is generally present with myopathy and with exercise intolerance, or most of the patients are generally asymptomatic. Then this adenosine deaminase deficiency, we know this is a part of SCID, severe combined immunodeficiency diseases, and chondroxy dysplasias are there. And this PNP, purine nucleotide phosphorylase deficiency, leads to your T cell mediated deficiency. So these last two diseases are actually manifestations is in the form of primary immunodeficiency disease. This myoadenylate deaminase deficiency is part of your myopathy, and other diseases present with your xanthine defect, uric acid defect, and CNS involvement. So HPRD deficiency is X-linked. It affects male only. Females are generally asymptomatic. And there can be a complete deficiency form that is known as Lesch-Nyhan syndrome, or there can be a partial deficiency form which is known as Kelly-Siegmiller syndrome. In case of complete deficiency, that is Lesch-Nyhan syndrome, there are presentations like hyperuricemia, self-mutative behavior, choreoathetosis, spasticity, and retardation. In your partial deficiency, there is no involvement of CNS, but there is only hyperuricemia. Increased PRPP synthesis overactivity. This is also X-linked disease. There will be increased PRPP levels that will lead to increased weight production. And generally, these patients, they present with gouty arthritis. There will be uric acid nephrolithiasis. And in some patients, there can be neurological hearing loss that occurs in some families. Adenine phosphorybal transferase APR deficiency. It is autosomal recessive condition. So in this condition, there is specific formation of your specific 2,8-dihydroxyadenine stones. So basically, this APRT enzyme is involved in metabolism of 2,8-dihydroxyadenine. So if this enzyme is defective, then this will be accumulated and can be crystallized into urine as your kidney stones. So there are two different forms of this APR deficiency. One is type 1 form, the other is type 2 form. Caucasians will have complete deficiency, that is known as type 1 form, and Japanese may have partial enzyme activity, and this is known as type 2 form. So treatment wise, you can provide allopurinol because the enzyme which is proximal to this 2-dihydroxyadenine is actually xanthine oxidase only, and that enzyme is inhibited by allopurinol. Coming to hereditary xanthinuria, deficiency of xanthine oxidase is there. So xanthine oxidase deficiency is there. Xanthine cannot be converted into your uric acid. So whatever is being excreted is excreted in the form of xanthine. So excretion of hypoxanthine and xanthine, and 2/3 patients will be asymptomatic in this condition, but 1/3 can have kidney stones, which will compose of xanthine. Coming to myoadenylate deaminase deficiency, so this is also known as MADD. So this myoadenylate deaminase deficiency, you will also read in your chapter of myopathy, where it is mentioned as one of the causes of your muscle disease. So primary disease is generally inherited autosomal recessive condition. So what this disease is mentioned as one of the causes of myopathy. So in this condition, some patient may have mild myopathic symptoms where exercise are the triggers. But generally in this condition, most individuals will be normal, asymptomatic. Therefore, if any patient who suspected of having this condition and having severe myopathy, then in such cases, another explanation for the myopathy should be sought in symptomatic patient with this deficiency, because generally this condition is asymptomatic. Then there can be secondary deficiency of myoadenylate deaminase deficiency, where secondary form can be associated with muscular dystrophies, neuropathies, inflammatory myopathies, and collagen vascular disease. This myoadenylate deaminase deficiency is, if you will read about your ischemic forearm exercise test for your myocardals and other diseases, then you will realize this is the condition which is on. This is the only condition which is associated with lack of increase in ammonia in that test. You can see the test online. You can see ischemic forearm exercise test. In that test, this is also mentioned. Then coming to adenylosuccinate lyase deficiency, this is autosomal recessive disease, can lead to profound psychomotor retardation, seizures, movement disorders, and all people are mentally retarded, and some can have autistic disease. Coming to pyrimidine metabolism. So whatever we discussed so far is purine metabolism, and now we'll go to pyrimidine metabolism. So pyrimidine and purine were involving your A and G, like adenosine and guanine. Now we will deal CTU, cytosine, thymine, and thymidine and uracil. So this figure little bit confusing, but to start from here. So what you can see that carbonyl phosphate and aspartic acid requires that your raw material. They will form uric acid, and uric acid will be forming your UMP, right? Uracil monophosphate, with the help of the enzyme. Enzyme is UMP synthase here. Okay. Once UMP is formed, then UDP can form. UDP can form UTP. It will be involved in your RNA, right? Or UMP can lead to CMP formation, cytosine. Then it will go CTP or CDP, deoxyTP. That will be in RNA or DNA. Then what can happen? This UMP can be broken down to uridine, or the CMP can be broken down to cytidine with the help of the enzyme, your 5' nucleotide enzyme. So this is 5' nucleotide enzyme which can lead to breakdown of your UMP and CMP. Okay. So once this deoxy UMP is formed with the help of the enzyme, your thymidylate synthase, your thymidylate monophosphate is formed. That can form TTP, and then you can go to your DNA. Okay. Then the deoxy TMP can be reduced thymidine with the help of enzyme thymidine kinase. And then this ultimately forms thymine, and thymine can lead to formation of beta amino isobutyric acid with the help of dihydropyrimidine dehydrogenase enzyme. So this dihydropyrimidine dehydrogenase enzyme is associated with breakdown of thymine as well as uracil. Uracil is broken down to beta alanine, and thymine is broken down to beta amino isobutyric acid. So we start from here, carbonyl phosphate plus aspartic acid forming uric acid, forming UMP with the help of UMP synthase. Then it will form your uridine with the help of 5' nucleotide enzyme. Here it can convert to CMP, then it is formed cytidine with the help of 5' nucleotide enzyme. Then here what you can see, UDP is being converted to TMP with the help of your thymidine synthase. Then thymidine kinase forming thymidine, then ultimately thymine, and this thymine uracil can be broken down to their end products with the help of dihydropyrimidine dehydrogenase. So what can happen? There can be defects, various defects in these enzymes that can lead to arrest of these pathways, and once these are arrested, then there can be arrest of DNA and synthesis. That's how they can lead to defects in the body. Okay, so this table is showing your some uh, less common but important diseases associated with your defects in pyrimidine metabolism. So if you see this uridine 5' monophosphate synthesis deficiency, it actually leads to your uric aciduria. So this UMP synthase enzyme is there. So this enzyme 4 is there. So once this is not forming, this enzyme is not there, then UMP will not form, and uric acid will accumulate. So this uric acid will appear in your urine. So that's how the name has come, uric aciduria. Then pyrimidine 5' nucleotide pyrimidine 5' nucleotide can be deficiency can be there. There can be superactivity also. So what can happen? There can be hemolytic anemia because of this pyrimidine 5' nucleotide deficiency. There basically stippling of RBCs, high levels of cytidine in urine. So basically, what is happening? DNA is not forming, DNA are not forming, and because of that, there is hemolytic anemia. In overactivity, there can be development delay, seizures, ataxia, language deficit, hyperuricemia can be there. In case of thymidine phosphorylase deficiency, there can be mitochondrial neurogastrointestinal encephalopathy and hypouricemia is there. Dihydropyrimidine dehydrogenase deficiency, that is your end enzyme, it can lead to seizures, motor and mental retardation, high levels of uracil, thymine, and 5-hydroxymethyl and low levels of dihydropyrimidine in urine. So what you can do, you can use high performance, your HPLC is there, that is high performance liquid chromatography you can use in urine or blood. You can see for these end products, and then you can actually, with some certainty, you can realize what enzyme is deficient there. Then dihydropyrimidinase enzyme is there, deficiency is not known, but seizure and antidietary is associated with that thing. Then uridopropionase is there, and that can lead to hypertonia, dystonia, telepathy. So this table is from Harrison. These diseases are mentioned there. Suggest you to remember them. At least you should remember these 5 diseases. Coming to again uric aciduria. So UMP synthesis deficiency, that is enzyme number 4 in the figure. So this actually converts uric acid to uridine monophosphate. So if this enzyme is deficient, what will happen? There will be high levels of uric acid. So what can happen? You must have read this uric aciduria in your chapter of uh, anemia, B12 and folic acid, megaloblastic anemia chapter. You must have read this thing. One column is mentioned as vitamin B12 unresponsive anemia. So this is the same thing only, uric aciduria. So what happens? These patients, they present with the hypochromic megaloblastic anemia that is unresponsive to vitamin B12 folic acid, and some patients can have growth retardation, neurologic abnormalities, and when you will check their urine, they will have increased excretion of uric acid, crystalluria can be there, and some patient can have obstructive uropathy. Treatment is simple because there is a break in this uric acid to uridine formation. If you provide uridine 100 to 200 milligram per kg per day, mostly this effect will be corrected. Coming to pyrimidine 5' nucleotide deficiency. So generally these patients, they present with hemolytic anemia with prominent basophilic stippling of the site. So if you see this slide, you can see these RBCs. What you can see that in some cells there is basophilic droplets are there. So this basophilic stippling is because of your this is condensed RNA. So what is happening? Because 5' nucleotide enzyme is not working properly, there is no formation of proper RNAs. So these blue dots are because of condensed RNA. So there will be accumulation of pyrimidine or citidine, diphosphate, choline, and this collection when happen, it induces hemolysis of these cells. No specific treatment for this condition. This is your inherited condition, and they can be acquired pyrimidine 5' nucleotide deficiency in lead poisoning and thalassemia. So there are three conditions which can lead to basically stippling. One is your congenital pyrimidine 5' nucleotide deficiency. Other condition is lead poisoning, and other condition is thalassemia. Okay. Okay. Dihydropyrimidine dehydrogenase deficiency, DPDD. So this is rate limiting enzyme in your pathway of uracil thymine degradation. So what happens? This is the enzyme, last enzyme, which is actually breaking down uracil thymine. So excessive urinary excretion of uracil thymine will be there. Non-specific cerebral dysfunction with convulsive disorders can be there. Moderate retardation can be there. Mental retardation can be there. No specific treatment is available as if now. Then coming to effect of medication, so many drugs are there which will actually interfere with the pyrimidine metabolism, and then that's how these are working. So this fluorodeoxyuridine and 5-fluorouracil, these both are anti-cancer drugs, and these both anti-cancer drugs, how do they work? They will be converted into your fluorodeoxyuridylate, and this fluorodeoxyuridylate will be actually interfering with your pyrimidine metabolism, and that's how it leads to cell cytotoxicity. So one another antibiotic is there, that is fluocytosine. This actually gets converted into 5-fluorouracil, and this happens with the enzyme cytosine deaminase. This cytosine deaminase enzyme is specifically present in your bacteria and fungi. So because of that, this effect occurs in only in pathogens and not in the human cells. This 5-fluorouracil is actually broken down, degraded with the help of enzyme dihydropyrimidine dehydrogenase. So what can happen? Suppose if some patient are having low level of this dihydropyrimidine dehydrogenase or some drugs which are inhibiting this activity, this 5-fluorouracil level can increase, and we know that 5-fluorouracil have a neuropathic effect. There can be chances of increased neuropathy. So this is how these drugs are working. One more drug is there, the leflunomide. So leflunomide actually inhibits de novo synthesis of pyrimidine by inhibiting dihydroorate enzyme. So because of this inhibition of this enzyme, there is arrested pyrimidine synthesis that leads to anti-proliferative effect on T cells. So this is how different drugs can work in your pyrimidine metabolism, and how do they actually work. So coming to our problem, our basic problem. Our basic problem case scenario was that there were 3 medicine residents. After double M duty, they wanted to do a mini party. One of the residents has hyperuricemia with uric acid of 11.8, and also 2 gout attacks in the past. So whatever they want to buy for drinking and for eating, they wanted to make sure that patient this one resident's uric acid should not increase. So coming to the figure, so as we have discussed already, so I'm going to tell now, red meat is not good. High purine content can also have some fat. Both are bad. Fish is good. Then your seafood is not good because seafood can have your high purine content. Then citrus citric acid, vitamin C, all this is good as it works as glucosuric. Tomato has high purine content, but it is a vegetable thingy. So because now we know that dietary fibers can lead to less bioavailability of purines and high this sensitization of insulin secretion. So in that way, it is good. It can be taken by patients. Then, as far as drinks are concerned, no to alcohol, especially beer, as it contains high coffee content. Some beer contains it, not all, but overall beer is the worst. Whiskey in middle, and then wine probably low amount, like 1 or 2 drinks is fine. Then coming to Coca-Cola, it is bad. It contains high amount of fructose, getting transported through glut 9. It also leads to hyperuricemia. Coffee is good. It contains methylxanthine. Methylxanthine will lead to your inhibition of your uric acid metabolism, and then also it increases insulin sensitivity. Then you have tea. Tea has no effect on uric acid. Then in the milk, full cream milk is bad because that fat can lead to resistance of insulin, but skim milk is good. So this thing can be taken. So this was the idea to mention you normal food materials and drinks in day-to-day life which can affect your uric acid level. I hope this discussion has been fruitful for people. If you have any queries and questions, you can contact us. Thank you. Thank you for your patience.